that Medicare for all will fix everything. We are always running into cost overruns in our Medicare program, and the reason why we're able to kind of maintain its solvency is because it's paid for by a pretty large payroll tax, and we're paying providers very low reimbursement to take those services. So hospitals and providers always complain about Medicare reimbursement. So I think moving the entire system to that would be problematic. They'd have to figure out a way to make it work a bit better. The other issue is that Medicare is kind of rife with fraud. Part of the ACA was dealing with, they bolstered the Office of Program Integrity at the Centers for Medicare and Medicaid Service. And if you listen to NPR or something like that, every couple weeks you'll hear about a $200 million sting operation that caught all this Medicare fraud. That was a pretty rampant abuse. And the way Medicare works is they're able to keep a very low overhead where they spend about 2% of their money in Medicare of all the claims that they process on administration. Because what they do is they take all the claims and they hire insurance companies to process those claims with no review. So in Medicare, as long as it's in the benefit package, it'll get covered. And the payment is extremely fast because all they're doing is saying to Blue Shield in a certain state, hey, process all these claims and we'll give you a 2% cut. So Blue Shield has an incentive to process as many claims as possible, drill through all the fee-for-service claims, and there's really no incentive for efficiency, and you really end up with doctors practicing a very volume-based system and getting away from this idea of value. And that's one of the big problems with Medicare. So in the ACA, you see that Medicare is empowered to do quite a few things to introduce value to their purchasing equation. So for those of you in Medicare Advantage plans, you'll notice that when you're signing up, it offers you, it tells you a premium, but also what's called a star rating that tells you the quality of care that that plan typically delivers. And if a plan has 4 stars or better, it qualifies for bonuses from the Centers for Medicare and Medicaid Services. So if they perform well on patient satisfaction, on medical errors, all these things that are part of the quality equation, they're considered a better value product and they get more reimbursement from the federal government. So it's kind of a pay-for-performance program. And that's completely different than what we see in Medicare fee-for-service, where doctors are just billing, 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 hospitals are billing, billing, billing. And it used to be 5 years ago that even if somebody developed a healthcare-acquired infection and there's a huge medical error during their case, the hospital still got paid for that case. And they still had an incentive to bring that person back and get paid again for that case, within 30 days. And now CMS is cracking down on those 30-day readmissions. They're cracking down on medical errors, and they're trying to make it so hospitals are getting paid based on value rather than volume. So I think it's moving in the right direction, but to assume that Medicare works really well, and if we expanded it to the entire population, basically, quadrupling its size, that it would be perfect, I think is probably a little bit simplistic. Yes?
I have a question. When it comes to Medicare, if I have, for example, Plan F, I guess it is, I can go get my second opinion, say at the Mayo Clinic, by making an appointment with whoever's the specialist there. With the new program, I have to stay within California.
So are you talking about Medicare Advantage, or?
No, I'm talking about Medicare, a supplement, PPO basically, is that you can go where you want as long as they take Medicare. Whereas now I get an EPO, which I'm not even sure about an EPO versus PPO, but I have to stay in California.
Right, so that has nothing to do with the Affordable Care Act, but I'll kind of explain what's going on. So we have 3 main types of health insurance companies in California, even covering California. So we have a PPO, Preferred Provider Organization, which means typically in network you will be paying 20% of the cost, and out of network you're responsible for 40% of the cost. It costs you more to use non-network providers. So non-network meaning they are not participating in the contract currently where they and the insurance company agree, this is how much I will get paid. So that's why there's this risk of they can charge you whatever they want and balance bill you for what Medicare or any other insurance company doesn't cover. So that's a PPO. An HMO would be something like Kaiser or HealthNet, where they have an agreement with a network of providers made up of medical groups and hospitals, and it's a closed network, meaning you cannot go out of network and get anything covered unless it's an emergency. So if you were trying to go to Kaiser and they said, well, we're not going to give you a dermatology referral because we don't think you need it. We think it can be handled with medication in the primary care visit. And you say, well, I don't agree with that. I'm going to go to Cedars for a dermatology visit. You have to pay completely out of pocket for the Cedars coverage. So in that case, you're just paying the 100% share. So HMOs typically use primary care physicians to act as a gatekeeper to keep you from going to high-cost elective surgeries, to high-cost specialists, things like that. Then the EPO is something that existed in the Healthy Families program for a long time, and it developed out of being in a rural area because if you're an HMO, you have to comply with pretty strict regulations in California that the Department of Managed Healthcare monitors. If you're an EPO, you have to put together a network, but it's called an exclusive provider organization, and it's not regulated in the same way. So your network doesn't have to be as good as the HMO network, but it's still closed. So an EPO is saying, okay, you have to pay for 100% if you go out of network, and you only have to pay a copay or a very low coinsurance if you stay in network. But the one difference with an HMO is that you're allowed to directly refer yourself to care. So you could go directly to a specialist if you're in an EPO, avoid your primary care physician, and just pay the copay, and there's no kind of barrier to keep you from seeing that specialist. But you're still not allowed to go outside of the network to see a specialist. So if you're in the Anthem Blue Cross EPO in covered California, for example, UCLA is in network, Cedars is out of network. So if you go to Cedars, you have to pay the full cost. If you go to UCLA, it's a $20 copay. So I think it's important to think about the network and the level of control you want your primary care to have over the referrals and services you get when choosing. Now in Medicare, about 3/4 of it is a fee-for-service program, meaning that it's called traditional Medicare. It's Part A and B, where you can go wherever you want as long as that Medicare physician is willing to take payment. So you can self-refer, you can go to go get second opinions, etc. If you sign up for Medicare Advantage, then you're signing up for a private plan. It combines your Part A and B coverage into what's called Part C coverage. They require you to sign up for a Part D plan on top of it. But typically you don't need to buy a separate supplemental plan because the benefit package and services delivered by that HMO product or that PPO product through Medicare Advantage are pretty robust and comprehensive. So then you are choosing in your area between 7 different plans that are in Medicare Advantage. And so this is only for people over the age of 65 or disabled. It's separate from covered California completely. And the only thing that the ACA did was change the bidding process and add those star ratings that carry with them reimbursement and these bonuses if you perform very well. But it does mean that managed care companies within Medicare Advantage can decide, well, I think the HMO is going to draw in fairly healthy people, and I'm going to make lots of money off the HMO. But the PPO is going to draw in people who like to go get second opinions and go use Cedars-Sinai, so I'm going to price that premium fairly high so that you have to pay extra on top of your typical premium to buy into that product. So you kind of pay extra for that flexibility. But if you do decide, you know, I'm going to sign up for the Medicare Advantage PPO and pay $50 more a month because I need choice, and then you switch to the EPO next year, you're depriving yourself of that choice you used to, you know, pay a premium for. And then you do have to deal with the fact that you have direct access to providers, but you're not allowed to go out of network. And if you do go out of network, you have to pay the full price. So you have to do the calculus of figuring out, okay, is $50 a month worth it to me to have that flexibility? And maybe it's not. Maybe the idea is, well, I'll probably spend $100 going to somebody out of network anyway, so why pay extra premiums month after month when all I do is go to 1 second opinion a year outside of network? So, you know, it depends on the plan you sign up for within Medicare Advantage about how much flexibility they give you, and you can sign up for plans that have lots of flexibility or sign up for plans like a Kaiser HMO that have no flexibility about the network.
Why did an area like Los Angeles end up with an EPO system versus PPO?
Because, well, so I believe they have both. So I think it's possible that the insurance company you're signed up with, so remember Medicare Advantage, it's not run by the federal government, it's run by private insurance companies. So Kaiser probably sells a plan that's an HMO. You know, Secure Horizons, which is a Health Net affiliated product, could sell an HMO, PPO, and EPO. Scan Foundation or Scan Health Plan might sell an HMO and a PPO. So it's possible that the company you want to work with doesn't have they decided to get rid of their PPO and create an EPO.
Okay, no, I'm talking about the Covered California has
Oh.
EPO versus PPO. And for Los Angeles, we're
So
kind
that's
of a PPO kind of people. I mean, you're either HMO or PPO, not the mid-range.
Well, I mean,
PPO.
so I think people like the fact that they're in a closed network, but have the ability to refer themselves. So it's kind of still better than a HMO. The real answer is that regulatorily it was easier. So the way that Covered California did the bidding process, they did RFPs, request for proposal, from all these different health plans, and the health plans had to put in bids and become a qualified health plan, a QHP. The Blue Cross EPO product, they did this kind of end around where they went through the federal system. So you'll notice if you look at the Covered California website, it says Anthem Blue Cross Multi-State EPO,
Okay.
which means that they are basically given a QHP status by the federal government, and they can then sell in multiple states. So, and the reason they do that is because they couldn't actually guarantee an adequate network in an HMO model according to California law. We have a law in California called Knox-Keene that was created in 1975 that says that for every physician, you can only have up to 2,000 patients for every physician and 1,200 patients per primary care physician. So if Blue Cross is coming in and saying, well, our network only has 2,500 patients per physician, we're not going to meet these adequacy requirements according to state regulation, they can still sell by being an EPO rather than an HMO.
Okay.
So it's just a network adequacy regulatory issue. So,
I have a couple of questions, and these are not my questions, but they're questions that are from people that have asked me. One is about the subsidies. People are concerned that if they accept the subsidies to help pay the cost, that somehow if they are property owners, that will somehow give, quote, the government access to put a claim against their property.
no,
And that is not a stupid idea because, and the reason that's not a stupid idea is because in much of America, there are states that require that if you get any kind of help, particularly medical help, that the trade-off is you give that state first dibs. If you die or when you die, the state has a lien against your property and that gets paid first. So the question that people are asking is, will the subsidies put them in a position of lien status potentially against their property?
no, it won't. So that's a very good point though. So in Medicaid, the federal government has an ability for states to do what's called estate reclamation for people who own a home or own resources and they use long-term care facilities or Medi-Cal coverage, and then they die and the state is then able to put a lien on the home or property for the amount of money that was spent supporting their care. So that exists in Medicaid, and it's currently federal law. States, most of them have laws related to it as well, but most states don't actually collect. So California, for example, they do estate reclamation for skilled nursing, but they don't do it for parents and kids with Medi-Cal. So depending on what category of Medi-Cal you fall into, whether you're a parent or child, or this new childless adult population, the mandatory population, then they won't do estate reclamation. If you're in an optional population, seniors and persons with disability using long-term care, then it's possible they would pursue it. But it's pretty spotty in terms of enforcement. Like in most cases, it doesn't happen. And there's a whole cottage industry of estate planning attorneys that tell you how to gift your house to your relatives so you don't have to worry about estate reclamation. So, so that's a Medicaid issue. That does not hold up in Covered California and with federal tax subsidies. So what will happen is that so one thing to tell people is you don't actually have to take the subsidies now. You can take them later. So they're called advanced premium tax credits, right? So you could actually forego them currently, buy whatever plan you want, as long as it's not a minimum plan. And then at the end of the year, when you're filing your taxes in April of 2015, you can say, well, I spent X amount of money on my health insurance through Covered California. and these are how many subsidies, this is how much in subsidies I didn't take even though I was eligible to. And then you get a big tax refund. So you could take the tax refund later instead of the tax credit now. So that's one way to say, okay, well, if you're worried about this, I'm telling you that it's not true, but if you want to protect yourself and you're really that concerned, why don't you wait? You can, if you're willing to forego the cash, or you're willing to forego the cash flow now, pay the whole price of the plan, and at the end of the year, reconcile everything and get a refund, then that's your prerogative. The other thing that happens, though, that protects people is that if you're at a subsidy level, so if you're under 400% of federal poverty level, they actually cap the repayment on your subsidies. So let's say you started out in the year at, you're filling in your application right now, you know what you made in 2012 tax return, you're kind of guessing what you'll make in 2013, you have no idea what you'll make in 2014, and you guess low. You guess, I'm gonna make $26,000 a year as a single individual. That puts you squarely in the middle of enhanced silver plan, big subsidies, and paying $50 in premiums or something like that. So you're getting maybe a $4,000 subsidy from the federal government, and it's getting applied to your bill every month for the whole year. If your income changes and you guessed wrong, your income might go up to 350% of federal poverty level, where the cap on your premiums goes up to 9.5% of your income, so the subsidy is much reduced or goes away. In that case, you are responsible for paying back some of the subsidy, but as long as you're still under 400% of FPL, I believe the subsidy repayment is capped at about $2,500. So you wouldn't have to pay the full amount back. The problem occurs if you go above 400% of federal poverty, so above $46,000 for an individual, then you have to pay the whole amount back. But you're still only required to pay back $4,000 on your tax return. But remember, since you're taking the tax credit, it's like any other IRS-related, liability you might have. You have to pay it back. You have to do a payment plan. It's a tax credit that you took early and you didn't actually deserve. So it's the same as if somebody takes an earned income tax credit, or doesn't qualify for student loan tax credit because they make too much money. All those things. So you should tell them it's not going to trigger a state reclamation from the state. This is a federal program with income-based tax credits. You may be subject to pay back some of those tax credits if you earn too much money this year. It's not going to follow you forever as long as you pay it back. And if your income doesn't change that much, they actually cap your exposure. It's not the whole amount. Yes?
In these lean times that we've had, why hasn't the state and federal been more aggressive in estate reclamation?
I think partially it's a political issue probably, and you don't want to disenfranchise a bunch of elderly people, partially because of political reasons, but also partially because if they're in a long-term care facility, they cost a lot less money than if they're in a hospital bed, right? So you'd rather have people in a skilled nursing facility where Medi-Cal is paying $150 a day rather than a hospital bed where they're paying $1,500 a day. And if you leave somebody in their home sitting there and then they end up in the ER, end up in this long hospital stay, you're probably spending 10 times as much. So, most states cover long-term care because of that issue. Some states, to save money, are trying to do home and community-based care. And that's an aspect of the ACA as well, where it used to be that you needed a waiver from the federal government for a 3 to 5 year period that you have to keep renewing and renewing and renewing to do any home and community-based care, and you'd have to demonstrate to the federal government that it was cost-saving. Now the ACA says you can change your state Medicaid program to include a home and community-based component without a waiver. So you don't have to demonstrate that it's cost savings, you don't have to renew every year, and you can create like a hospice-related kind of service, or do like a pilot program where you might have curative care with palliative care at the same time. So you're not basically saying, well, if I go into hospice, I'm going to die. You're saying, well, if I go to hospice and the following things happen, I can still get care that's somewhat curative. So that tends to be more money saving. And if it's going on home and community-based care, Medi-Cal is typically paying $60 to $70 a day, not $150 a day, and certainly not the $1,500 a day that they might pay for a hospital bed. So there's kind of a spectrum of services that people need when they're older, disabled, need long-term care. And I think the reality is if you deliver things in a less acute environment, with lower paid staff because people need less oversight, it's a lot cheaper to do.
Is there anything in the works to start closing up all the distribution of the estate loopholes?
Not that I know of. I mean, I think it's still something that can be used. And, you know, most states aren't super aggressive about it, but some states might be when there's an economic downturn. I would say, considering we didn't see a huge response to that from 2008 to 2011 or so, I wouldn't expect anything to happen now about it because the economy is kind of getting better. But if we end up in another big recession 10 years from now and that's the only place to cut in Medicaid, you may see that type of thing happening.
It's frustrating, I think, to see some people where they've got the Mercedes in the driveway. Oh, that's my son's. Oh, this is my son's house, and they're collecting Medicaid. That's what I mean by closing up some of the loopholes.
Yeah, so I mean, so that population still is required to do an asset test. So in that case, you know, they are actively breaking the law by doing that. But you know, I guess it's an issue for reporting it to the Medicaid department, reporting it to CMS's Program Integrity Office, and they do pursue Medicaid fraud, and they have created a database that's monitoring Medicaid fraud across the states, because before states didn't share data at all. So I think that's getting better in general, but they're not going, I think from Medicaid's perspective, that's kind of a small piece of the pie from a fraud perspective. Most of the fraud is going on in providers, and I'm sure a lot of you saw the alcohol drug programs had a huge fraud scandal over the summer as they're moving into the Medicaid programs. The Medicaid program got all this blame for running this fraudulent ADP program, but in actuality they had just gotten handed the keys by the agency that was running it, and fraud had kind of run rampant. And they were chasing Diana Dooley and Toby Douglas around on 60 Minutes because, you know, there are all these fraud issues in the alcohol drug program, and they're addressing them now. But I think often, because Medicaid programs are very busy trying to expand Medicaid, these issues don't come to the forefront unless there's big media attention or something triggers it, and then they have to address it. So you see legislation when they're in crisis, basically. Well, I will let you go now. Thanks for staying.
Thank you for